Welcome everybody to the WK Research and Health webinar at a later time than usual at 8 p.m. today. And that's because we're extremely lucky to have Dr. Mark Popenhagen from Colorado. And because of the time difference, it's 1 p.m. there and 8 p.m. here. Mark will talk about demystifying palliative and end-of-life care, optimizing quality of life. Now, before I pass it on to Mark, very brief introduction to Mark. Mark is board certified health psychologist specializing in pediatric pain. He serves at the University of Colorado School of Medicine and Children's Hospital, Colorado, with expertise in pain management, epidemiology, and pediatric palliative care. Today, we're extremely lucky to have Mark attend or give this presentation, and he'll explore palliative and end-of-life care for individuals with EB, emphasizing the importance of interdisciplinary care, symptom management, grief, and bereavement, while advocating for further research to improve care for this vulnerable population. And on that note, I will pass it on to you, Mark.
All right. Well, thank you so much, everyone, for having me. Hang on. I'll get squared away here. Can you see my screen?
Not yet.
Not yet? Okay, 1 second. Sorry, everybody. How about now?
No, nothing.
Nothing? 1 moment. Let's see.
Okay.
I see your screen. Let me try sharing again.
Yep.
And share. How about now?
Now we can see it.
Excellent. All right. All right. Okay. Sorry, everybody. I'm doing this on my little laptop, and there we go. All right. Well, again, thank you all so much for having me today. Really excited to talk with you about this. And so we'll just get started. Most of this talk is going to be based on the consensus guidelines for provision of palliative and end-of-life care for people living with EB. This article is open access, and I'll show you how to get to it if you want. It was published in September of 2023. Including myself, we had 21 authors from 11 different countries on 6 continents. So this was truly a group effort, and I thank everyone for all of their work on this paper. A couple other disclosures. Those guidelines were funded by DEBRA UK. Thank you. And they were also endorsed by DEBRA International. That QR code there in the corner does get you to the article. If you're interested in it and you miss it now, I'm going to have this here at the end. But even though DEBRA UK and DEBRA International I'm affiliated for this project, they didn't have anything to do with they don't have anything to do with the final recommendations or the practice or presentation. Also to let you know that very soon, hopefully by the end of this year, the patient and family version of this article will be published. It's done, it's ready to go. We're just finalizing the publication stuff. So just want to make a couple acknowledgements to start. First of all, this topic I know can be very difficult for some, can be confusing, can be very sad. But for some, it can also give a sense of relief and acceptance. And every person in this room, every situation, every person you'll meet to talk about this is unique. Their situation is different. And so just kind of keep that in mind. And wherever you're watching this, whenever you're watching this, I want you to hopefully feel that this is a safe place that is without judgment. There's no shame. There's no comparison. It's just going to be a safe place. So overall, we're going to be talking about palliative and end-of-life care for folks living with EB. And again, talking about interdisciplinary care, symptom management, grief, and bereavement. And then, of course, as always, we need more research. I'm going to start off with a few definitions because I want to make sure that we're all on the same page. Because throughout writing this paper, I learned very quickly that these definitions can mean very different things in different countries or even different regions within the same country. So I just want to make sure we're all on the same page. Forgive me if these definitions match with what you know already, but they may not for all. So first of all, what is palliative care? Whoops, sorry. I'm sorry, hang on. Did I just get rid of my slides? There we go. Okay, so what's palliative care? Good grief. Sorry. All right, so what's palliative care? For our paper and for the purposes of this talk, we're going to use the 2020 World Health Organization's definition, and that it's not EB specific, so this fits for anything, but folks living with EB can fit within this. So palliative care is essentially focusing on improving comfort and quality of life of patients diagnosed with a potentially life-limiting illness by trying to both prevent and relieve suffering over the course of a person's entire life. So this is really important because this kind of care can begin very shortly after diagnosis, can start at birth, but could also start at any time in the process. And the important thing to know is that based on this definition, palliative care is not necessarily end-of-life care. And I'll get to that here in a second. But basically, palliative care means trying to make whatever life a person has left, whether it's 5 years, 5 months, 50 years, right? Whatever time they have left, making that time worth living. So then what's hospice care or end-of-life care? This is comprehensive care that's usually comfort-focused, family supportive, and for the person who has a serious illness and is approaching end of life. Okay, so where palliative is broader, now we're focusing in a little bit. All attempts at cure are stopped. Of course, there is no cure for EB yet, but for other ailments, all attempts at cure are stopped. And it's really important to know that no attempts are made to either prevent the dying process or to accelerate it. So this is not necessarily, this isn't euthanasia or anything like that. This is just allowing nature to take its course. Treatment focuses on quality of life, symptom management, comfort, and most important to me is dignity. So comfort care. Comfort care is provided pretty much right there at the end of life, and again focuses on symptom control and pain relief and quality of life. Some folks will argue, well, this kind of care is just giving up. Well, nothing could be further from the truth. Comfort care is actually fighting for your loved one by doing pretty much whatever it takes to prevent or stop suffering. Okay, so it's pretty heroic care. You keep the person as absolutely comfortable as humanly possible. So if we consider palliative care as this big circle here, hospice care or end-of-life care is part of that, and then comfort care is just a small little bit. So again, for the purposes of this talk and of this paper, this is where we were. So therefore, all EB-related care is considered palliative. From birth to the end, all care is palliative. It's not hospice care, it's not end-of-life care until it is. Okay. So survivorship. Survivorship refers to kind of the overall health and well-being of the person living with EB from the time they're diagnosed, often at birth, until the time they pass, regardless of whether that time is measured in days, weeks, years, or even decades. So if we look at this picture, and this picture is also going to be in the patient family version, if you look at the far left side of the screen, from birth, really at that point, you're optimizing quality of life. Everything you do, make life as good as possible. And as you progress along, the amount of time and effort spent on comfort, potentially on grief and bereavement, that gets more and more and more as we pass along towards death. All care, start to finish, we're always focusing on pain and symptom management, also focusing on physical, emotional, spiritual, and family support. That stuff starts at the beginning and goes all the way through. It never stops. So interdisciplinary care. Interdisciplinary care is a term that I like to use much more than multidisciplinary, because multidisciplinary really means a group of individuals who are working in parallel. Interdisciplinary care is care where the group is really, really working together towards a common goal. Now, if we consider the person living with EB and their carers to be the center of the team, the center of the care, then we consider that all of these folks that are popping up here, all of these folks are optimal members of a team who's caring for a person living with EB, right? Seems like a lot. It is a lot. And this is the optimal. Now, I know in some countries, in some areas, and here in the US with insurance, not everything is possible, okay? This, again, is the most optimal group, and we do the best we can with what we have, right? Now, it's also possible that the group may not be in the same room together or even in the same region, right? Thankfully, with technology like what we're using here today on Zoom, you can talk with folks all around the world and learn all about these things. So good communication is hugely important, right? It's so important to also remember that the opinion of the person living with EB matters, and it matters a lot, even if that person is a child, right? Little kids, they deserve to have their voices heard and respected. Sure, they're not adults yet. In some countries, they may or may not have legal rights as an adult does, but still their voice really needs to be heard and respected. Here in the US, kids cannot provide consent, but they can provide assent. So consent is a legal term. Assent is they would agree or disagree. And it's so important to always encourage folks to ask questions, okay? The team should be explaining all treatment options, even the option of no treatment, right? Because that still is also an option. So symptom management. Symptom management is, of course, a very big part of palliative and end-of-life care. But the symptoms are unique for every person that you're working with, or you yourself. You are going to be so different than anybody else. So it's really important to focus on what's important to you, right? Maybe it's pain relief, or maybe to know how sedated you may or may not be, right? Talk about side effects. A person might choose to be more sedated to have less pain, and another person may choose, you know what, I'd rather be awake so I can interact with my family and my friends, and yeah, I'll endure my symptoms, but I really want to be awake. So this is really important to ask these questions and to focus on. And if you're the person living with EB, tell your team exactly what you want. It's okay. You have you should be able to have the right to do that. And please do understand too that as your symptoms progress, as the disease progresses, you can change your mind at any time about your treatment plan, right? You may change it quite a few times, right? Because as you go through your life experience, your decisions may change. And that's totally okay. Pain management, of course, is always a major part of the treatment of EB. There are a lot of different options, whether they be medication related or non-medication related. Artificial tears and optical bandages can be extremely helpful to take care of corneal abrasions as a person's eyes may get more dry towards the end of life. But even they can be used all along. For any of the people who prescribe that are watching this, it's important to know that you may need to increase the pain medications and into doses that are way beyond what anyone else is going to be considering normal. For those who are receiving those medications, those doses are okay, right? It doesn't mean you're a drug addict or anything else like that. These doses are what are necessary to keep you comfortable, and that's okay. Towards the end of life, all efforts should focus on improving comfort, no matter what. Don't worry about addiction. It's not going to be something, especially at end of life, it's not going to be something that you need to focus on. You've got other things to do. Palliative sedation is another really interesting and very useful tool that we use. And what that is sedating a person to stop the negative symptoms, right? The pain might be so much, or other symptoms may be so out of control that we end up sedating a person. This is not euthanasia. This is just a person is given medication, they sleep. Now, a person may die while under palliative sedation, but the purpose of the sedation is not to end the person's life or to even shorten it. It is to allow comfort. All right, itch management. Of course, I don't need to tell any of you, itch management is also very important. Again, lots of different medication options and non-medication options. And again, just like before, just with pain, or it's not just with pain, rather, we want to focus on improving comfort no matter what. Do know that opioid pain medications can sometimes increase itch. If you're on a medication that makes you more itchy, please talk to your team. There are sometimes medications and other things that can be done, or there are other non-medication options. Moisturizers, emollients, and bath oils may sometimes cause itch as well, depending on what's in them. Again, and talk to your team if there are any issues. One trick with emollients is keep them in the refrigerator. Cool or cold emollients, if the person can stand them, can be very soothing on the skin and help reduce itch, at least for a little while. Distraction works well. Pressing or tapping on the skin as opposed to scratching, blowing on it, again, applying something cool or cold. These things can all be helpful. Vibration can be helpful. So little hand vibrators that you might put on your neck. Sometimes those are good for putting near the area, as long as they're not causing friction. Here in the US and maybe in other places too, there's a little device called a Buzzy Bee. I get nothing from them, but we use them sometimes. And it just looks like a little bumblebee, or it looks like a little ladybug, and it vibrates, and kids like it, and you just put it on, and it works pretty well. Rinsing bleach or salt off the skin after a bleach bath or a bath with pool salts in it can be important. You can also talk with your team about whether you're putting too much or too little salt or bleach into the water. But if they're drying the skin, talk to your team about it. Wounds, of course, still happen, as they always do. And as always, get wounds checked out that don't heal, or they're not healing normally, or wounds that just are acting weird, right? They're acting differently than every other kind of wound that you've ever had. Get those checked. And of course, when in doubt, check it out, right? Because why not? If you're not sure, that's the safest thing to do. Go get it checked. All right, so feeding and constipation. This is, of course, very important. When this first recommendation here is quite controversial, I know, but the research backs this up, that NG tubes or nasogastric tubes really ought not be used except at end of life. And even then, only if they cause less discomfort and there's no other way of feeding, but comfort is key. If it's not comfortable, if it's causing blistering in the nose or throat or on the face, really ought not be using it. So really something to consider. Of course, as always, to manage constipation, we want to optimize the intake of fiber and fluid, and especially for folks like where I am, currently I'm at 6,000 feet altitude. Fluid is super important to avoid constipation. We also want to manage that constipation because, of course, any pain and discomfort with anal fissures or blistering internally, externally, this is not something we want to have anyone experience. Now, of course, just as it's really important to treat the physical challenges caused by EB, it's just as important to address any of the mental and emotional health needs of everyone involved. So the person living with EB, their carers, their family, their friends, and even the providers. So it's important to get good support. And so that support could be formal, could be also informal. You might need some in the short term, you might need some long term, or maybe you need it sporadically. Look for what you need and go get what you need. They help with so very many things, right? Any stigma, trauma, bereavement, loss, and just dealing with EB in and of itself. Research bears out that support systems really help with a sense of self, making people feel fulfilled socially, personally, spiritually, and really just feeling good. And if you don't know how, or you're feeling really isolated, talk with your medical team. How can you build better personal support system? What else is out there? What else can you do? Because they really may know of things. All right, other support, psychological support is also really important. Depression, anxiety, these are things that many people have, whether they have EB or not. But getting good psychological support, especially as we move towards end of life and comfort care, it can be so very important. And it can be important at different time periods, right? So after getting the diagnosis, that's a big time. It might not be the person with EB because they might be a baby at this point. But of course, what about the parents? They're going to need support too. Getting support in how to make end-of-life decisions, right? How do I go approach this? How am I, I've never died before. What am I going to do? How do I work through this? And then, of course, in times of bereavement after a person dies. But, accepting help is not a weakness. It's actually a strength. So ask for help, accept that help. When people offer help, they don't think you're crazy. They're just trying to help, okay? And if you're not ready for it, just say no, thank you. But if you are, then accept it and do what you can. It's also really important, and this came up a lot when we were working on the paper. Of course, folks living with EB need to have the same opportunities to feel useful and to be contributing members of society, just like everyone else. Sure, okay, it's a chronic ailment. Yes, there may be some other challenges that go along with it. But as you all know, there's so many things that you can do, right? You don't have to stop just because you have EB. So you live your life, right? Live your life despite having EB, right? EB is just a part of you. It's not who you are. It doesn't have to define you. Make friendships, laugh, play, go do fun stuff, explore, right? As much as you can. You're not EB, okay? You have it, but you're not EB itself. All right. Now, as a person's life begins to kind of come to an end, there's a time where the EB team or the healthcare provider is going to start shifting the approach towards ensuring a person's utmost comfort, right? Especially when managing pain, itch, other symptoms that are the highest priority for that individual. Remember, we talked about before, it's all about what the individual wants. So these priorities, again, like I said earlier, these priorities can change over the course of time. I'm not going to play the video here, but this is an excellent video. I've never met Dr. Mannix, but it's excellent animated step-by-step journey through the dying process. It's good for families, individuals, whomever. But it's a really great video. And if you want, I'll pause for a second, take a snapshot if you have your phone, and you can snag that web link there on YouTube. Okay, we'll move on. At end of life, a dying person's body does not have the same needs it once did when the person was active. Okay. They're going to potentially naturally lose interest in eating and drinking. In fact, giving them more to drink, making them eat, this may actually make them feel much more uncomfortable, and it may be more distressing. So we want to not push. So if a person says, hey, not thirsty, not hungry, let it go, let it be. It's not a time to increase feeds at night or fluids at night, because again, there may be much less need and definitely less interest. If a person may start sleeping more, reduce mobility, you may find that their bandages don't need to be changed as often or even at all, and they may not want you to, because it may just be causing more discomfort. A person's kidneys and liver may begin to fail or stop. And again, this makes it much more uncomfortable if you're pushing fluids. So don't do that. And the bandages, you may find they don't have to be changed as often because they're not taking in as much fluid and there won't be as much exudate. Talk to your team about which medications you may or may not need. If, as you're at end of life, you may not need things like statins or blood thinners or other medications, especially the ones that are causing horrible side effects, right? Avoid those. Now, don't stop any of these medications on your own. Talk to your team first, because the side effects of stopping things can be worse than taking them. So please talk with your team before making any changes on your own. Now, I know I talked about nutrition a little bit a moment ago, but there's a few more points here. Again, like I just said a moment ago, giving extra food or fluid can make a person more uncomfortable, so don't. Regular mouth care is super important. Just having a clean mouth, a fresh mouth, can make a person feel good, right? And some will tell you that it's more important to them than eating, right? But good mouth care is important. And there's so many different ways to provide comfort care and with nutrition and such. Each team, each institution, whichever, may have different protocols. So if you're not sure what the protocol is where you go or where you are, ask. Urinary catheters. This also comes up quite a bit. Remember, if a person isn't drinking very much, their urine output is going to really decrease. So urinary catheters are only important if they're increasing comfort, reducing soiling of dressings, or when a person is so unable to move, or because it makes them so tired or it's so painful. Whatever you can do to make a person feel comfortable, but also dignified, right? We don't want a person to be soiling themselves because that doesn't feel good either. So as a person approaches end of life, there's some really good points for discussion to have with your team. These are can be done right at end of life. It's usually best, though, to think about these questions, to talk about these questions as we move closer. So, for example, what's a good day look for you? Right? What's it look like? So for me, a good day is sitting outside looking at the mountains, right? For other folks, they don't want that. Maybe they want to be, surrounded by 500 people or surrounded by nobody, right? What's a good day look for? And how do we make that happen, right? Who do you want to be making medical decisions for you if you can't, right? Very important. Most of these things, get them written down, okay? What kind of life-saving measures, if any, do you want as end-of-life approaches? Do you want CPR or chest compressions? Do you want medications given, or do you want nothing? At what point do you want oxygen fluids feeds to be stopped, right? Never or right away. Whatever it is, make sure that your team knows what you want. And at what point do you want monitors to be shut off? Monitors can be extremely annoying. Granted, they're helpful for nursing staff and others, but if you're having to listen to a monitor beep all night long, it's not fun. And you lose a lot of sleep trying to listen to that thing. What do you need to make you or your child feel most comfortable, right? Maybe a child needs to have a comfort object like a teddy bear near them or their blankie, or maybe a person wants to have music on in the background. What are these things that a person needs? Ask them. How much pain relief do you want? Do you want pain relief if you're going to have less alertness, or would you rather be just out or more sedated, right? So this is helpful for the team to know. What medical treatment do you not want, right? We often ask folks, what do you want? But we forget to ask, what do you not want? Because they seem like the same question, but they're not. Because people will have very, very specific things that they don't want done. Is there anywhere that you want to have your hospice care? Some people really want to have their end-of-life care at home. Right? They're most comfortable there. That's where they want to be. And others are like, nope, I don't want it to be at home. I need to be in the hospital, or I want to be in a hospice facility. I don't make this happen at home, right? Get answers to these questions. Anybody else that you want or don't want you to have around you when you're dying, or to be notified, right? Family, friends, who do you want to know? Who don't you want? A tough question, but an important one is, where would you like to die, right? Do you want to die at home, in a facility? Do you want to die outside, right? That may or may not be able to happen depending on the facility, but where do you want to die? What do you want to have done for your body when death occurs? Maybe there's cultural or religious practices that need to be followed. Make sure these are written down beforehand so that people know, so that they can respect you even after death. Make sure that a person's possessions and financial affairs are in order. And a really fun question to ask, and it may sound morbid and creepy, but I've done this with so many patients and they love it. How do you want to be remembered? Right? Teenagers especially love this because they're afraid everyone's going to forget them. But when you remind them, no one's going to forget you. But how do you want them to remember you? What's important for them to know so that they can remember you by? The answers that you get to these questions are amazing. Now on to grief and bereavement. Now, let's see here. Sorry, grief is universal. Pretty much everyone goes through a period, has some time of grief. And grief is simply an emotional response to any kind of loss. Sure, it could be a death, but maybe it's a loss of a job. It's a loss of an opportunity, a loss of an expectation, right? Could be anything. But bereavement, however, is the specific period of grieving that follows the death of a loved one, right? So again, grief is universal, any kind of loss, and it can come out in so many different ways. These are just a few, but it can really manifest in different ways, up to and including death of the bereaved. Now, that's not to lay guilt on anyone, and it's much more rare, but it's possible. And again, as we talked about the importance of support earlier, it's the same as true here. Talking to others about your grief experience can really get you through this and really help you out. If I had a nickel for every time I said this first thing, I'd be a very wealthy man. But it is so important for everyone to know that everyone grieves in their own way, in their own time, even to the same event, right? It's all different for everyone. There is no quote unquote right way to grieve or best way to grieve. No, there's people grieve in their way. And we don't judge, we don't compare. Well, I'm grieving more than you are. No, everyone grieves in their own way. Little kids especially, but even kids into adolescence may grieve death very differently than adults, right? Because they don't understand it in the same way that we as adults do. Of course, teenagers have a much better understanding, but little kids, they don't get it, right? So a couple examples, and I've seen both of these. A little kid comes running up. So is Uncle Bob going to be done being dead in time to come to my birthday? Because I really want him to come to my birthday. No, sorry, sweetie. Uncle Bob's still going to be dead at your birthday. And then the kid runs off. 20 minutes later, comes back. So does that mean Uncle Bob's not going to be coming to our house for Christmas either? Yes, that means that, yep, he's not coming to Christmas either. Okay, and then off to playing. You don't have to give a big, huge explanation or, a lecture or anything like that. Just answer simply, age appropriately, and they'll figure it out. Yeah, another example. The last funeral I attended, the deceased son was about 3, and he was running all over the funeral home, and playing, showing everybody his toys, doing all kinds of things. But the minute a new person came into a room, he'd run over to them, point to the casket, and say, "That's my daddy." And then sometimes, not always, because sometimes the toys were way more important, he would grab the person's hand and run them up to the front so that they could see his dad. It was amazing. And the way he did it brought so much joy and laughter to the room, which would, ordinarily a very sad event. He brought levity, and it was a wonderful thing. These are just a few common feelings that people have when experiencing grief and bereavement. All of these feelings are okay. All of these feelings are normal. There's nothing wrong with them. Okay? All totally normal, all totally fine. You may also have any of these reactions or multiple of these reactions, right? You see on there smiling and laughing. Sometimes people are horrified when, oh my goodness, smiling, laughing, a person just died. Why? Because that's how they cope. Maybe they remember a time where the deceased made them laugh so hard that, milk came out their nose, or, they are remembering some other fond event, or even smiling, knowing that a person's suffering may be done. Some people with religious beliefs may smile because, oh, you are now with whomever, right? Our creator, whoever, their belief system is with. So any one of these is totally normal, and they're all okay. Everyone grieves differently. Grief comes up, of course, at the time of death or any other loss, But these things also resurface during big milestones, right? Holidays are huge, birthdays, anniversaries. These are times when big feelings come up. Sometimes a person may not even realize that the significant day is coming up, but they're feeling off, they're feeling sad. It's like, what is going on? Oh, it's Uncle Bob's birthday tomorrow. That's why, right? And your body remembers, you remember, but just acknowledge this, and it's okay, right? Moving on with your own life, it's not forgetting, it's not abandoning that person. And you're never going to get over a loss like that, but in time you'll move forward, right? And you might be taking tiny steps. You know, some people may jump forward pretty quickly. Others may take tiny, tiny steps that other folks can barely even see. But you notice, and you're going to just day by day move forward. And it'll never be easy, but it'll get easier, right? Never easy, easier. And it may not feel like it in the beginning, but as you move forward, things will begin to work for you. Now, some people choose to have another child, remarry, maybe provide care for somebody else. You're not replacing the person who died, okay? You're just taking another step in your journey. You acknowledge that pain that you have, you honor that person, you honor the past, and you cherish the future, right? Because that person's life stopped doesn't necessarily mean that yours has to, okay? It's okay to have a future. All right, now to talk about some future research. All of the recommendations here and in the paper were based on the available research. As you can imagine, that list of research was quite small, okay? We could only publish in the paper what was available. In the patient and family version, we kind of got a little more leeway to give opinion, but the other, we couldn't, okay? So that's why some of the recommendations that you might see, it's like, well, that's not my experience. Well, that's the experience that's in the research. Your experience could be different, and it may be absolutely the right thing and great and wonderful, but that's all we could write down. So I'm really begging the research community to do more research, to find better practices for end of life, right? Here in the US, we don't talk about death, right? We should, we don't talk about it much. And we need to know better how to talk about it. We need research based on EB subtype, right? A person with simplex is very, very different than a person with recessive dystrophic or severe junctional, right? I'm not saying one is better or worse than the other, it's just different. And knowing how to approach end of life for each EB subtype is important. There's almost nothing out there on EB subtype. What about age? Children are different than adults. But also, what of folks who live in areas where there are few medical resources, right? And how do beliefs across regions, across countries, how does all that apply? And then looking at different cultures, different ethnicities based on folks living with EB. There's nothing out there on that. And then of course, well, what of times if there's periods of war or economic insecurity where you don't have all the resources, maybe you don't have any resources, right? How do you get things done? And looking at it, there's really a need for looking at ethics about medical futility, withholding care, altering care, especially at end of life. And I purposely didn't get into it because it's a whole talk all in of itself, but the ethics of terminating care or euthanasia, or otherwise known as the Groningen Protocol. These are things where there's so little research, but we need so much more. Okay. I'm going to open it up now for questions, and the QR code there is the one to use to get the article, or you can use the web address there, the rdcu.be, that one. That's available. It's the same article. If you can't do a QR code, use the other one. It's open access, so it's free to anyone. Anyone on the planet who wants it, there it is. So yeah, so I'll take questions.
Thank you, Mark. There isn't any questions coming through, but while people are thinking about questions, I guess one of the key messages that I got from your amazing talk was there's no right way or wrong way. It's about what's best for you as an individual and also as a family.
Absolutely.
Yep.
Yep. There's with so many things, you know, so many questions that we're asked. I mean, I'm a psychologist, so a lot of the questions I'm asked, the answer is it depends. You know, and when it comes to palliative care, end of life decision making, you don't want my answer. You want your answer, because your answer is what's right for you. Last year, I guess, had a amazing little baby I was working with, and her incredible parents. She was born with severe junctional EB, and her parents decided that they wanted to help her live, right? Being alive, yeah, we could have done that, but they wanted her to live, and they wanted to make memories with her. And so they asked me, and it was an amazing question, like, can we take her on a road trip? I said, well, of course, go. And then I got a message from them, you know, a couple weeks later, can we put her in the ocean? I said, yeah, she's going to scream, but you can put her in the ocean. I said, she's only going to scream because the water this time of year is freezing cold. So you're going to scream too when you get in, but you're going to have great memories. And sure enough, they did. They went to the ocean, they went to the Grand Canyon, they went to all of these wonderful places, making these amazing memories. And that was the best thing in the universe for them. Other people, that would have been the worst thing ever. But for them, that's what they wanted, that's what they needed. And so it's so individualized. And that's one of the things I love so much about doing this kind of work I do.
Just more of a practical question or practical advice. What's the best way to talk to somebody about your needs? You know, I can imagine people being quite nervous to ask a question.
Sure.
You know, is there any prompts that you can provide to families so they can ask the right question and not be shy or nervous about it?
Sure. Well, the answer to that question is, again, it depends. Some of it depends on how old the person is, right? If you're talking with an adult, you're going to be having a pretty different conversation than with a small child. But it's okay to talk about death with kids. Very often they know. And they've maybe heard it already from the parents who thought the kid couldn't hear it, but they could. They may have heard it at the doctor's office or in the hospital, or they may just know. And I've had so many little kids just know. And so for the parents to talk, to listen, to let their loved one ask their questions, and to say, you know, to the person, what questions do you have? How can I help you? Right? In this time of your life, how can I help you? With an adult, all those questions I asked, you can ask them, right? It's also okay to say, hey, I don't know how to ask these questions. I don't want to be insensitive, but I don't know how to ask these questions, and I want to help. How can I help you? And Also, maybe person, what questions do you want to ask me? And then you write them down, especially if you don't know the answer. I don't know the answer to that. Let's ask your doctor the next time we see them. Let's ask your hospice nurse next time we see them. Let's write all these questions down so we don't forget, because your questions are so important. This is, we're going to write them down. Now, I saw a couple.
Yeah, there's a couple of questions that come through the chat room.
Yeah.
Can you see them, Mark? Or shall I read them out?
I'm gonna try. If you, oh, there's the chat. Okay.
Yeah. So are there any things we should or should not do to be as supportive as possible of someone who has been bereaved? Yep. Is there language that is more or less appropriate?
Yep, that's an excellent question. Saying things like, I'm sorry, that's always okay. It's also okay to say, I don't know what to say. Right. And just to acknowledge it, kind of put it out there. I'm so sorry. I have no idea what to say, but I don't. One thing that I really recommend to not say is to say, I know how you feel, because you don't. You know how you feel. You know how you feel in a similar situation, but you don't know how they feel. And for a lot of folks, that seems very condescending and inappropriate. If a person is religious, they may really want people to bring religion into it, but if a person is not, they don't want to hear it, right? A person may also not want to hear they're in a better place now, right? Because if they don't believe in an afterlife, well, the better, great, they're dead. What's the better place? Also, please don't lay blame. I had a patient many years ago who died, and his mother did everything to keep him alive, everything. And when he died, a mom from another room came over and said, well, if you had prayed harder, he'd still be alive today. Please don't do that. Please don't. That mother was devastated. She pretty much became suicidal because her whole time taking care of him, what else can I do? What else can I do? And we kept telling her, nothing. Love him. Be there. Hold his hand. Talk to him. But that one person who probably meant well just crushed her. So please don't lay blame, even if it's well-intended blame. It doesn't help.
There's another question in the chat room. Thank you for your talk. Pain management seems like such a multidisciplinary area. Is that the main focus of your research group?
It is really important because end of life for some folks can be very painful, right? For many reasons, not just EB. So some of them are related to EB, some are not. I talk a lot about pain because I'm a pain psychologist. I'm also the associate director for our pain service at Children's Hospital Colorado. So pain is pretty much all I've done for the last 25 years. So it's what I know. But that said, even if I wasn't a pain psychologist and wasn't on the pain service, what I have experienced with patients who've died or any of the end of life process, pain comes up a lot.
Yeah. I don't think there's any more questions coming through.
Okay. I did have my email on the last slide there. So if anyone thinks of questions later, go ahead and email me, no big deal. I get to emails as fast as I can. Sometimes it's a week or so, but all right. Just send them along. Yeah, I'm happy to chat with anybody.
No, I just want to say, Mark, thank you very much. It's been an amazing talk. It's one of those conversations that people try to avoid.
Yep.
You know, but you've made it such an easy presentation.
Thank you.
So I want to say really thank you very much. So before I end the webinar today, I just remind people of our next presentation. Let me quickly show my screen. Hopefully you can see that, which is we're going back to our normal 1 p.m. timing. The next one's on Wednesday, 9th of July at 1 p.m. And it will be presented by Dr. Silvatna Karina, who's an MRC fellow at the University of Manchester, who will be talking about RNA's regular adhesion forces in epithelial and mesenchymal repair. So please do register for that, and we'll see you in July. In the meantime, thank you very much for attending, and have a good evening or a good afternoon or a good morning, depending where you are. So before we leave, I'd just like to thank Mark one last time for an amazing talk. Thank you, Mark.
Thank you.